Good morning, good afternoon, good evening to everyone. I'm Dr. John Ward. I'm the director of the Coalition for Global Hepatitis Elimination at the Task Force for Global Health in Atlanta, Georgia. It's my pleasure to welcome you to the third version of our discussions regarding hepatitis testing in different settings to help achieve elimination goals for hepatitis B and hepatitis C. We want to thank our sponsor for Abbott helping make this webinar series possible. Today we're going to be looking at the role of hepatitis testing to prevent mother-to-child transmission of hepatitis B virus. Now, the cornerstone of preventing mother-to-child transmission of hepatitis B is timely birth dose vaccination. And that's effective in about 75% of the time in preventing mother-to-child transmission. But to improve that prevention further, you need to know the status of the mother, and that requires testing to deliver hepatitis B immune globulin to the infant in a timely way to improve coverage protection to about 94%. But then if you want to really to virtually eliminate it, you need to add additional interventions such as antiviral prophylaxis for the mother to lower that viral load and prevent the breakthroughs through those other protective measures. And that's what we're going to be looking at today is hepatitis B testing, and particularly how to integrate that with other global initiatives which have preceded it to eliminate mother-to-child transmission of HIV and syphilis. We have a great lineup of speakers from Thailand who will be discussing their program that's been established for quite some time, followed by Cambodia with an example of a program just getting underway, and then regional perspectives from the Pan American Health Organization and from the Africa Regional Office of WHO, followed by perspectives from the WHO headquarters in Geneva. And we have some discussants joining us from Chai that we're very excited about. So let's move along, and we'll begin with Thailand. They have developed a video that shows the steps in their program to show how a pregnant woman proceeds through the program with counseling and then with testing, and then that will be followed by a presentation from Dr. Nasaman Wallapakorn, who is a MD PhD at the Chulalongkorn University in Bangkok. She's a pediatrician clinically, and has done a lot of work both in virology as well as in clinical research around hepatitis B, and she'll be describing the program in more detail. So let's begin. Thank you.
สุขคลินิกฝากครรภ์ของโรงพยาบาลแม่และเด็กมีหญิงตั้งครรภ์มารับบริการวันละประมาณ30รายร้อยละ54ของหญิงตั้งครรภ์มารับบริการก่อนอายุครรภ์12สัปดาห์เจ้าหน้าที่คลินิกฝากครรภ์จะให้คำแนะนำแก่หญิงตั้งครรภ์ทุกรายที่มารับบริการฝากครรภ์ในครั้งแรกเกี่ยวกับการตรวจเลือดเพื่อค้นหาโรคติดต่อทางเพศสัมพันธ์3โรคได้แก่ไวรัสตับอักเสบ B HIV และซิฟิลิสไม่ว่าจะมีอายุครรภ์เท่าใดหากสามีเดินทางมาด้วยจะให้คำแนะนำพร้อมกันทั้งคู่สามีภรรยาแต่หากสามีไม่ได้มาด้วยเจ้าหน้าที่จะให้คำแนะนำแก่หญิงตั้งครรภ์ก่อนนอกจากนี้เจ้าหน้าที่จะแนะนำให้หญิงตั้งครรภ์อ่านความรู้เพิ่มเติมในสมุดบันทึกสุขภาพแม่และเด็กส่วนที่3ความรู้สู่การปฏิบัติเพื่อแม่ลูกสุขภาพดีในหัวข้อ5เรื่องที่ต้องตรวจเพื่อลูกน้อยปลอดโรคปลอดภัยหรือสามารถดูวิดีทัศน์จากการสแกน QR Code ด้านหลังของสมุดบันทึกสุขภาพแม่และเด็กเพื่อให้เข้าใจยิ่งขึ้นในหัวข้อการฝากครรภ์ครั้งนี้ตรวจเลือดหาอะไรหากหญิงตั้งครรภ์ยินยอมให้เจาะเลือดตรวจหญิงตั้งครรภ์จะเซ็นชื่อยินยอมให้เจาะเลือดด้วยความสมัครใจจากนั้นเจ้าหน้าที่จะแนะนำให้หญิงตั้งครรภ์ไปเจาะเลือดที่ห้องเวชศาสตร์ชันสูตรที่ห้องเวชศาสตร์ชันสูตรเจ้าหน้าที่จะทำการเจาะเลือดหญิงตั้งครรภ์จำนวน1หลอดตรวจทั้ง HBs antigen anti-HIV และ VDRL การตรวจทางห้องปฏิบัติการเพื่อวินิจฉัยโรคไวรัสตับอักเสบ B และ HIV ห้องปฏิบัติการโรงพยาบาลแม่และเด็กจะส่งซีรั่มไปตรวจ HBs Antigen และ Anti-HIV ที่กรุงเทพ RIA Lab โดยจะมีตัวแทนจากบริษัทมารับตัวอย่างเลือดทุกวันในช่วงเช้าและออกรายงานผลการตรวจภายใน 1-2 วันเทคนิคที่ใช้ในการตรวจได้แก่ CMIA การตรวจทางห้องปฏิบัติการเพื่อวินิจฉัยโรคซิฟิลิสได้แก่การตรวจ VDRL สามารถตรวจได้ที่โรงพยาบาลแม่และเด็กโดยวิธี Rapid Plasma Reagin หรือ RPR สามารถออกรายงานผลการตรวจภายใน 1 วันถ้าผลเป็น Reactive จะทำการส่งซีรั่มไปตรวจ TPHA ที่ห้องปฏิบัติการของโรงพยาบาลราชบุรีโดยรอผลยืนยันประมาณ 2 วันสำหรับการมาฝากครรภ์ครั้งแรกของหญิงตั้งครรภ์ทุกรายโครงการฝากครรภ์คุณภาพของกระทรวงสาธารณสุขจะออกค่าใช้จ่ายในการตรวจเลือดให้ทั้งหมดเมื่อผลการตรวจถูกส่งกลับมาที่ห้องปฏิบัติการเจ้าหน้าที่ห้องปฏิบัติการจะตรวจสอบความถูกต้องของผลการตรวจหากพบผลตรวจผิดปกติเช่น HBs Antigen Positive Anti-HIV Positive หรือ VDRL Reactive เจ้าหน้าที่ห้องปฏิบัติการจะรีบแจ้งไปยังเจ้าหน้าที่คลินิกฝากครรภ์ทันทีแต่หากผลเลือดปกติเจ้าหน้าที่คลินิกฝากครรภ์จะเป็นผู้แจ้งผลในวันนัดตรวจครรภ์ครั้งต่อไปกรณีที่ตรวจพบพาหะไวรัสตับอักเสบ B หรือ HBs Antigen Positive จะมีการแนะนำให้เจาะเลือดเพื่อส่งตรวจ HBe Antigen โดยส่งเลือดไปที่กรุงเทพ RIA Lab รอผลประมาณ 2 วันหากผล HBe Antigen Positive แพทย์จะแนะนำให้ฉีด HBIG หรือ HBIC แก่ทารกแรกเกิดทันทีหลังคลอดโดยสามารถเบิกค่าใช้จ่ายได้ทุกสิทธิการรักษาแต่หากไม่มีผล HBe Antigen หรือ HBe Antigen เป็นลบเจ้าหน้าที่จะให้คำแนะนำเรื่องการฉีด HBIC เป็นรายบุคคล
Good morning, everyone. My name is Nasamon. I'm a pediatrician and a researcher at Chulalongkorn University. It is my pleasure to share our experience and progress on elimination of hepatitis B mother-to-child transmission in Thailand. Chronic hepatitis B infection affects 250 million people worldwide. In the Southeast Asia region, about 39 million people are chronically infected with hepatitis B, accounting for 15% of global infections. In Thailand, infant hepatitis B vaccination has been incorporated into the EPI since 1992. It is estimated that there are 2 million HBV carriers in Thailand. Most were people born before the implementation of universal vaccination. The likelihood of developing symptoms of acute hepatitis and chronic HBV infection is age-dependent. Less than 1% of infants younger than 1 year develop symptoms of acute hepatitis, while 5 to 15% of children 1 through 5 years of age and 30 to 50% of people older than 5 years are symptomatic. The risk of developing chronic HBV infection varies inversely with age. Approximately 90% of infants infected during the first year of life develop persistent infection, compared with 25 to 50% of children infected between 1 to 5 years of age and 5 to 10% of older children and adults. Perinatal or early postnatal transmission is the most important source of chronic HBV infection. In order to achieve elimination of HIV, HBV, and syphilis mother-to-child transmission, these targets were established by the World Health Organization. The program targets for maternal and child care service included antenatal care coverage and births attended by skilled health personnel of at least 95%. In terms of HIV and syphilis prevention, the program targets aim to achieve antenatal screening and treatment coverage of at least 95%. Achieving these targets will lead to a reduction in the rate of MTCT of HIV to 2% or less, and less than 50 new pediatric HIV infection or congenital syphilis cases per 100,000 live births. For HBV, the antenatal screening, hepatitis B birth dose and third dose vaccine coverage should exceed 95%. And finally, the seroprevalence of HBs antigen in children should be less than 0.1%. A tiered approach is proposed in order to introduce a comprehensive package of interventions for EMTCT of hepatitis B, starting from hepatitis B birth dose and follow-up doses, screening of pregnant women, linkages to care and follow-up of exposed infants, administration of hepatitis B immunoglobulin or HBIG for exposed infants. As of June 2017, the World Health Organization guidance was established on the use of antiviral agents for HBs antigen-positive pregnant women with high HBV DNA levels or HBe antigen positive. The Department of Disease Control, the Ministry of Public Health Thailand, has established the Thai National Guideline for Elimination of HBV MTCT in 2018. They have adopted 4 strategies, which include screening for HBs antigen in all pregnant women, antiviral prophylaxis in high viral load or HBe antigen positive mothers, administration of HBIG in infants born to HBs antigen positive mothers, and maintenance of infant Hep B vaccine coverage. For the screening for HBs antigen in all pregnant women, individual counseling for HBs antigen, HIV, and syphilis blood testing in pregnant women is performed on the first visit to the antenatal care clinic. Since 2016, the lab cost has been provided free of charge for pregnant mothers using the budget from the National Health Security Office. The rationale for this free service is to promote healthy pregnancy. Between 2019 and 2020, the coverage of HBs antigen testing in pregnant women was over 95% at the antenatal care service. In terms of lab test, rapid test or lab-based assay can be used. When rapid test is positive, lab-based assay either by ELISA or CMIA assay has to be done to confirm the results of the rapid test. In our previous study, it shows that the false positive rate of rapid test HBs antigen was about 3.1%. This slide shows the approved HBs antigen rapid test kits for use in Thailand. These kits were approved by the Department of Medical Sciences, the Ministry of Public Health. This is the workflow diagram for HBs antigen screening at the antenatal care service. Some women have been diagnosed with chronic HBV infection and received antiviral therapy before pregnancy. In women with chronic HBV infection and elevated liver enzymes, it is recommended to consult the hepatologist to provide antiviral treatment. For pregnant women with unknown HBs antigen status or HBs antigen positive in the previous pregnancies, HBs antigen testing by rapid test or lab-based assay is performed. Women with HBs antigen positive results will be informed to collect blood samples for HBe antigen, ALT, and creatinine. The seroprevalence of HBs antigen among the Thai population varies according to age. According to the National Survey in 2014, the seroprevalence of HBs antigen was significantly higher in the people born before the universal vaccination program than those born after the program. Among people between 20 to 40 years of age, the prevalence was around 3%. Another study conducted in pregnant women also shows that the HBs antigen seroprevalence among Thai pregnant women was around 3%. Couple and family counseling is performed in HBs antigen positive pregnant women. However, the lab costs for husband and family members are not covered by the Universal Health Coverage Scheme. Couple counseling and testing on HBV is not performed routinely in all pregnant women due to the low prevalence of HBs antigen in the universal hepatitis B vaccination era. We are now moving on to the second approach towards hepatitis B elimination, which is antiviral prophylaxis in high viral load or HBe antigen positive mothers. The natural history of chronic HBV infection is characterized by the 4 phases, including a period of active viral replication without active liver disease or immune tolerant phase, a period of active viral replication and active liver disease or immune active phase, a phase with low or absent viral replication and remission of active liver disease or inactive carrier, and the last phase, which is reactivation with active hepatitis and progressive fibrosis. In persons infected perinatally, the immune tolerant phase is more frequent and can be prolonged to 10 to 30 years. Most of the Thai women of childbearing age who were infected perinatally are in the immune tolerant phase. Some may be in the immune active phase. The seroprevalence of HBe antigen in the HBs antigen positive Thai women is as high as about 33 to 40%. Associate Professor Surasit and his team has conducted a study evaluating HBe antigen as an indicator for antiviral prophylaxis. He found that among 92 antiviral naive HBs antigen positive women, 25 of them had HBV DNA level of more than 200,000 IU per ml, and 24 of them tested positive for HBe antigen. Only one case, or 1.6%, of high viral load mothers would miss antiviral prophylaxis due to the HBe antigen negative results. 80% of HBe antigen positive women had high HBV DNA viral load. If antiviral treatment was given to all HBe antigen positive women, 5 of them will be overtreated. In summary, HBe antigen is associated with active viral replication and high viral load. Transmission of HBV from mother to child is more common in children born to women who are HBe antigen positive. According to accessibility, the cost of HBV DNA level in Thailand is about 65 USD per test, and the cost of HBe antigen is only 10 USD per test. According to the study of Professor Surasit, overtreatment occurs in 16.6% and undertreatment occurs in about 1.6% when using HBe antigen as an indicator for antiviral prophylaxis. HBe antigen test is affordable and acceptable. Therefore, Thailand uses HBe antigen as an indicator for antiviral therapy when HBV DNA testing is not available. This is the workflow diagram for TDF prophylaxis at the Antenatal Care Service. All HBs antigen positive women were tested for HBe antigen. In case the HBe antigen is negative, the woman received routine antenatal care. Although there is a very low risk of traumatizing the baby's skin by instrumental delivery, such as the use of vacuum extraction and forceps, the Thai guideline recommended that instrumental delivery should be avoided if possible. In case HBe antigen is positive or the HBV DNA viral load is above 200,000 IU per ml, tenofovir as an antiviral prophylaxis is started after the 28th week of pregnancy and continued until 1 month postpartum. According to the Thai National Guideline, creatinine level should be checked at baseline and at 1 month after administration of TDF to monitor renal toxicity. Although there is a low risk of exacerbation or postpartum flare after cessation of TDF, the Thai guideline recommended to test for ALT level at 6 to 8 weeks postpartum and re-evaluated whether the woman needs to continue the treatment for their own health. Regarding the progress towards the high coverage of TDF prophylaxis, the Department of Disease Control, Ministry of Public Health, Thailand, launched a pilot project for EMTCT of HBV using TDF prophylaxis in 12 provinces in May 2018. In 2019, 3 more provinces were added, and in 2020, 11 more provinces were added. Nevertheless, it covers only 34% of the provinces in Thailand. Regarding the process of drug administration, the hospital pharmacist registered through the web-based system, and TDF will be delivered to the hospital within a month. According to the report from the pilot provinces, the coverage of TDF in HBe antigen positive or high viral load pregnant women was around 58% in 2018, which was the year when the program was launched. In 2019, the coverage increased to 97%. In 2020, when there was an outbreak of COVID-19, the coverage decreased to 37%. The COVID-19 pandemic has a huge impact on the elimination of mother-to-child transmission program as healthcare personnel were diverted to tackle the pandemic. The key challenges for Thailand in achieving high coverage of antiviral prophylaxis included the limited number of provinces in the EMTCT program, the uncoordinated approach among programs. For example, HBV and HIV registered database are separately provided. The unawareness of the risk of HBV MTCT in pregnant women with HBe antigen positive and the unawareness of immunoprophylaxis failure, which can occur in 1% of infants who received immunoprophylaxis. In summary, the key pillars that lead to Thailand's success on Hep B EMTCT included the high coverage of timely Hep B birth dose due to high proportion of births in health facilities, the high coverage of third dose infant hepatitis B vaccination, the policy on screening for HBs antigen in all pregnant women, and the strong technical body exists to guide immunization practice in the country, and the strong health service system which allows integration of lab screening into the antenatal care services. Nevertheless, several challenges remain to be solved. We need to increase the availability and reduce the cost of HBe antigen and HBV DNA viral load, and to promote the laboratory network. The cost of lab tests should be covered by the Universal Health Coverage Scheme. We need to increase awareness among the healthcare providers on the risk of HBV mother-to-child transmission and development of chronic infection when infection occurs perinatally. We need to promote the use of tenofovir prophylaxis to prevent mother-to-child transmission, in addition to timely birth dose, especially in settings where HB is not always available or affordable. So efforts should focus on expanding coverage of TDF. We need to implement only one system to administer and monitor treatment for HBV and HIV. We need to promote early antenatal care visits at less than 12 weeks of gestational age and couple and family counseling. There are also several challenges in childcare services. We need to increase the availability of HPIC, and HPIC should be provided free of charge for all infants born to HBs antigen-positive mothers, not just for infants born to HBe antigen-positive mothers. We should increase vaccination coverage in marginalized populations where population movement and remoteness may have limited the effectiveness of vaccination programs. Follow-up of HPV-exposed infants to identify new cases of chronic HPV infection and feedback these data to improve the service is also an important strategy. Last but not least, I would like to express my sincere gratitude to my mentor, Professor Yongpu Varawan, and our team at the Center of Excellence in Clinical Virology, Department of Pediatrics, Faculty of Medicine, Chulalongkorn University. Thank you very much.
Thank you very much, Nasimon, for that excellent overview and really a thorough examination of your program and the success. And it's really, a little disturbing to see the impact of the COVID-19 pandemic on the declines in the number of women getting the antiviral prophylaxis. Wanted to give Dr. Surasit Chattowan-Watana a chance to comment. He's a professor of obstetrics and gynecology in Chulalongkorn University as well. He's really considered the national expert on maternal screening for HIV, syphilis, and hepatitis B now. Just wanted to see if there were some additional perspectives you would like to add at this point to add on to Nasimon's comments and presentation, please.
Thank you, John. May I share my slide, my screen?
Yes. And we have up to about 5 minutes, if you can.
Yes, just only a short time. I would like to share the activities for the triple elimination of mother-to-child transmission of HIV, syphilis, and hepatitis B in Thailand. We have screening for these 3 infections for more than 20 years. And as Dr. Nasamon said, the program that really successful is the HIV EMTCT, because we have the national program for PMTCT of HIV in the year 2000, and we use the monitoring system to evaluate about the process in each step of the treatment or care in pregnant women, right? The screening program, the ARV treatment, the monitor for the fetus and newborn. And we use the HEART regimen for all since 2010. And we improve or we change the national guideline every 3 to 4 years. And this year we will change the regimen to dolutegravir base. And when we have the problem about syphilis re-emerging in about 5 to 6 years, the past 5 to 6 years, we start to active surveillance the syphilis in the newborn in the same system with the HIV. And like Dr. Nasamon said, we have to include the hepatitis B infection into this monitoring system to be success. For the hepatitis B, we have the universal HBV vaccination for the newborn since 1992, and we pilot the tenofovir for the E antigen positive in 2018. And this is our result. You can see that in 2019 we have a new case of the HIV even in 100,000 live birth, or about 1.1%. But if we use the adjusted rate, it's about 1.97%. We have the congenital syphilis, about 15 per 100,000. For the hepatitis B S antigen, the prevalence in the children less than 5 years in 2014, there's about 0.1%. The process to get the target can pass the target in all aspects. In summary, I think that achieve goals for triple elimination by the 2030 is possible, but your program should include reproductive health, maternal and child health care program, and it should be supported by national policy and universal health coverage. The lab service is also important to have the laboratory services in the whole country. The other important factor is about monitoring and surveillance system to know that where the problem occur, and we have to have many stakeholder involvement, both obstetricians, pediatricians, nurses, pharmacy, and also in the pregnant women themselves. I think that this code is interesting, that challenges are what make life interesting, and overcoming them is what makes life meaningful. Thank you.
Thank you so much. I'll remember that. Very good. Thank you both for a very excellent presentation, and we'll come back and have more time for discussion. So let's move on to hear about the program in Cambodia. We'll be hearing from Dr. Saman Chorn, who is the lead of the Prevention of Mother-to-Child Transmission program in Cambodia. And he's been working with the Ministry of Health for quite some time in this area with the dual elimination of HIV and syphilis, and now integrating screening for hepatitis B. And, we'll be hearing from him by video.
Good evening, good afternoon, and good morning. My name is Dr. Samnang Chon. I'm the technical advisor of the PMTCT program of National Maternal and Child Health Center, Phnom Penh, Cambodia. It is my great honor to share with you the approach to integration of HBV into antenatal care services perspective in Cambodia. And first of all, I would like to express my sincere thanks to the organizer, the Coalition for Global Hepatitis Elimination, all partners working to support the PMTCT program in Cambodia, the Ministry of Health, the National Maternal and Child Health Center, the HIV program, the Communicable Disease Center of MOH, and all participants who join us tonight. Here is my agenda. I will go through an overview of hepatitis B and antenatal care in Cambodia, the ANRS evidence generation and result, the incorporating of HBV intervention into PMTCT program, and challenge and opportunity and way to go forward. About Cambodia, as you may aware, Cambodia is a country situated in Southeast Asia with the current population around 15 million, and annually we have around 365,000 pregnant women. And the rate of antenatal care for these women who get at least one ANC visit is very high since many years ago. It's around 95%. The prevalence of hepatitis B among the pregnant women was found to be high, around 4%, and the children aged under 5 is around 0.6%. And the MTCT rate of hepatitis B from positive mother to children was around 10%. Antenatal care and hepatitis B vaccination in Cambodia was a strong foundation. Cambodia has introduced HBV vaccine nationwide since 2005, and then in 2007 we start the birth dose vaccine. It means a vaccine to be given at birth at 6, 10, and 14 weeks. And according to recent data of the National Immunization Program, the vaccine of hepatitis B was around 73%. Cambodia also started the PMTCT program in 2008 by first formulation the national strategic plan to introduce the HIV into the current health system, and until the 2017 we have expanded to introduce syphilis testing as well into the HIV program. And also at that time the ANRS Taprung study was launched, and the objective of the research was to identify the effectiveness of a free immunoglobulin strategy to prevent HBV mother-to-child transmission based on the detection of HBs antigen and HBe antigen using rapid diagnostic test algorithm and tenofovir treatment for those eligible, and early started vaccination for all infants at birth. It means within 2 hours. So the primary endpoint of the study is to estimate the proportion of active HBV infection in infants at 6 months of life, evaluated by hepatitis B S antigen and confirmed by DNA. Here are the protocol for the study. So we include the HBs rapid diagnostic test at 7 health facility and 5 maternity. And then if the hepatitis B is positive, we continue to test with the hepatitis E rapid diagnostic test. And if the hepatitis B and hepatitis E antigen positive, we introduce the tenofovir treatment and follow-up at the delivery. We also provide the vaccination early birth for all children and monitor the result 6 months after birth. As a result, we found that among the 21,000 pregnant women who screened, 6.3% were found to be positive for hepatitis B surface antigen. And among those, only 338, equal to 38% of that pregnant women was enrolled for tenofovir treatment. It is to be noted that the tenofovir eligibility is based on the positivity of hepatitis B E antigen, and also in case the hepatitis B E antigen negative, but with the elevation of the ELT more than 40 IU per liter as the predictor of high HBV DNA viral load level. And so the result have found a well correlated between the using of hepatitis B E antigen and ELT of more than 40 with the viral load with the high sensitivity and specificity. Also, the research have proved that the strategy of early vaccination and tenofovir based on hepatitis B antigen and ELT provide an acceptable strategy to reduce the HBV transmission from mother to child. Among the tenofovir eligible group and the not eligible for tenofovir group, the rate of positivity among the children were found around 1%. It means 0.98% among the non-eligible group and 1.26% among the eligible group. So based on this finding, PMTCT program has put a lot of effort to introduce the hepatitis B intervention into the existing program. Since the year 2020, a public health program for hepatitis B is developed. The discussion has been started to revise the national strategic plan, guideline, and operational plan to introduce the hepatitis B intervention. And as any other program, funding resources remain a big challenge. However, Cambodia was successful to get the funding support from the Global Fund under the Resilient and Sustainable System for Health to integrate the intervention for hepatitis B into the antenatal care services. It means incorporate to HIV, syphilis, TB, and malaria activity. And from the year 2021 and onward, we will finalize the PMTCT guideline and national strategic plan to become the triple elimination guideline, and then start to introduce the screening for hepatitis B surface antigen in capital city of Phnom Penh with the tenofovir treatment in case of available, and also introduce the hepatitis B vaccination for the children after birth. It means within 2 hours. This was built upon the strong commitment, political commitment of the MOH for the triple elimination strategy, which include the National Center for HIV, Dermatology, and STD, and Communicable Disease Control Department of the MOH, as well as the active involvement of the Technical Working Group for PMTCT program. So advocacy discussion is still going on between the MOH to get the financing for hepatitis B in the public health program. In terms of HBV intervention, we have also integrate into the existing health system, and strategy will focus at every level of health facility. At the health center level, we will screen the pregnant women at ANC services for detect the HBs antigen and give the vaccination at birth, at the delivery. At the maternity of the hospital, we also screen for hepatitis B as antigen at the ANC visit, together with HIV and syphilis, and also provide the HBV vaccine to the baby immediately after delivery. And for the hospital HBV services, we will conduct the evaluation for hepatitis B E antigen or hepatitis B viral load or ELT to determine the eligibility for treatment with tenofovir. And if in case eligible, we will start the tenofovir treatment for women from the 24 to 28 week of gestation, and also continue to monitor the mother and baby after birth. So the monitoring and system will be for hepatitis B will be also integrated into the HIV and syphilis PMCCT program. But we still have a challenge as well as the opportunity to move forward. So our future goal is to commit the national scaling up. We mean to screen for hepatitis B antigen for all pregnant women, as well as the certification for hepatitis B E antigen and ALT and treatment with tenofovir, with the aim to extend the care and treatment services outside the capital of Phnom Penh to other provinces where resources available. And also the financing of hepatitis B program is still a barrier, as so far the tenofovir is not yet available for HBV treatment, and often patients will pay around $30 per month at the national hospital. So further need to improve the affordability of tenofovir treatment for affordable to all pregnant women who need it. We also need to continue and maintain the existing PMTCT program by strengthening or build the existing effort for HIV and syphilis, as well as the technical working group to further strengthen the intervention of hepatitis B, and especially to continue to strengthen the both dose coverage for vaccination. Also, the interdepartmental coordination and collaboration to strengthen this program is needed, especially in the area of treatment linkage of positive hepatitis B pregnant women into the public health services or program, and also data sharing between National Maternal and Child Health Center and Communicable Disease Center need to be strengthened. Thank you for your attention.
Thank you very much. Excellent overview. I'm calling Dr. Amy Okamoto and her colleague Savanta Ho to give some other perspectives about this program that you've been involved in.
Hi, yes, thank you, John, and good morning, good afternoon, good evening all. Thanks for joining. Yeah, I really enjoyed as well listening to the Thailand presentation when Dr. Nassaman kind of reviewed reaching the same conclusion in evidence of HBe antigen correlating well to viral load, being more affordable than viral load and able to implement it. So we hope to follow in those footsteps. It was great to see it worked into a universal health coverage scheme. We think the biggest challenge facing Cambodia right now is around the financing. Particularly while a surface antigen test may be cheap, less than $1. And for us, the e-antigen test, at least for the research, was able to be less than $2. As Dr. Samnan mentioned, the cost of tenofovir is still about $30 a month, which it should be cheaper as it is for many HIV programs, and it's not widely available. So in order to be able to screen and then refer these pregnant women to tenofovir treatment, we're really going to have to find financing to build up a public HBV program. So I think we could use help with data generation around the financial cost effectiveness, both within Cambodia and globally. I know we see a lot of that for hepatitis C being cost effective and even cost savings to treat. And I think we need to see more of that for hepatitis B to get more leverage for financing and advocacy. So it's great to see that Cambodia has the strong backbone of dual elimination, as well as high coverage of antenatal care and the birth dose vaccination. So we're looking to keep this up, continue strengthening it. This week, we actually have the 3-day consultative workshop to finalize the guidelines and the strategy around PMTCT. So we're looking forward to continuing to move forward to triple elimination by 2030. Thank you.
Thank you so much. Savanka?
Hi, good evening, good morning, and good afternoon, everyone. Thanks for giving me the floor to share some thoughts. As Amy mentioned, that we continue to discuss and finalize the strategy and guidelines for triple elimination. So I'd just like to highlight a couple of things that have just been agreed upon this afternoon. You know, something like demand generation for HPV screening and treatment among pregnant women. I think we want to leverage the community volunteer group to also share the knowledge, and especially providing, you know, where they can find the screening and how important is the screening of HPV important to all the women in the community. And also we want to secure the supply chains, which is, as Amy mentioned, which is one of the critical points to ensure that we have the army, and also we have the weapon, which is all commodities and treatment to be available at all levels, that we plan to have those test and treat available in all services. In addition to that, we are really proud to have to hear the continued efforts from the Ministry of Health and Economic and Finance in order to provide more attention, financial commitment, allocation of the budget into the HPV care programs, and also attention in order to, you know, improve the service quality, and especially complying to the validation criteria as planned. So I think, as you all know from the Thailand presentation, you know, we all want to improve the data management, monitoring and surveillance, laboratory service, and human rights, and complying with the gender equality in the PMTCT program as well. Thank you so much.
Thank you so much. We don't want to forget about the health needs of the pregnant woman. That's for certain in these efforts. And I think that you touched on that with health equity. Quickly, I'm interested, of the 3 diseases, which is the most common in pregnant women? I'll ask that for Cambodia and for Thailand.
For Cambodia, it would be hepatitis B. So the rates are around 4% in our pregnant women. General population-wide, it's around 1.6% or 0.6% for HIV, and syphilis is less. So HPV is the biggest burden and the last one to be addressed.
Thank you. In Thailand, Dr. Suraset?
Thailand, hepatitis B is highest, it's about 3%. For the HIV now, it's a 0.6% prevalent, and for the syphilis now it's increased from 0.05 to 0.5 in 10 years. Yeah. Now it's the re-emerging of the syphilis in especially in the young pregnant women.
Thank you. Dr. Nassimon?
But the highest is hepatitis B.
Okay, thank you. And that's an important point.
Yes, totally. I totally agree with Dr. Surasit. Thank you.
Thank you. Thank you all. Let's move on to some regional perspectives. The Western Pacific region has been also very active, of which Cambodia is a member state. But the other region has been the Americas, or the Pan American Health Organization, which committed to triple elimination goals in 2017. And we're very fortunate to have Dr. Leandro Sereno here, who's the viral hepatitis focal point for the Pan American Health Organization. He's an infectious disease physician from Brazil originally, currently living in Washington, D.C. And I'll turn it over to Leandro to share more information about PAHO and activities in the region. Leandro?
Hi, thank you, John. Thank you for the introduction. And I would like to thank you and Lindsay for this opportunity to present what you're doing here in the Americas region to address the quadruple elimination, the triple elimination, but Chagas, as we have included as well. And in this presentation, I'd like to share some of the components and the perspectives of this, the framework that we have developed and we are implementing here, as well as some of the experiences that we heard from the field. And I would like to start, I hope you can see well my screen, and I would like to start here with an overview of the evolution of the EMTCT initiative. And focusing here on the region, the first time that countries, the member states in Americas have committed to the elimination of congenital syphilis was in 1995 with a PAHO resolution. But we've seen real progress happening on the syphilis field when it was integrated with the HIV EMTCT efforts in 2010, when countries agreed and established regional goals for the elimination, for the dual elimination of EMTCT of HIV and syphilis. And after this, PAHO has started implementing this initiative with establishing a regional secretariat dedicated to the topic, and also establishing a regional validation committee to monitor the country's progresses and to validate. And in 2015, Cuba was the first country to be validated for the dual elimination of the EMTCT, followed by additional 6 countries in 2017. And based on these experiences and these achievements, in 2016, member states agreed to reinforce that committed to the dual, to the EMTCT initiative, and requested PAHO to expand this initiative, and starting with to other diseases, starting with hepatitis B and Chagas, as it is a regional aspect of the region, the Chagas disease. And in 2017, we revised, updated this initiative and published the EMTCT Plus, what we are calling now, framework, which defines the quadruple elimination here in the region. And the development and implementation of this new framework, we can identify 3 main stages, which was the first one, the development and the discussions, the technical discussions, where we agree and discuss on the interventions and targets to be included in the framework, followed by the validation of this framework with countries and partners, and the publication of the framework in 2017, followed by some piloting activities and piloting implementation in a few selected countries. And more recently, we are discussing on criteria and methodologies to monitor and to validate to monitor the progress and to validate the elimination in countries. Focusing on the Chagas and hepatitis B, as HIV and syphilis, we have already a well-defined methodology and process to validate. And the rationale, the idea to integrate these, the hepatitis B and Chagas into this framework was to build on lessons learned from the EMTCT initiative of HIV and syphilis. And one of the most important lessons, I would say, would be that the interprogrammatic coordination and implementation. And we've seen that, especially for syphilis, we've seen real progress when it was integrated with HIV, with the HIV efforts. And we intend to leverage on this and to integrate hepatitis B as well on this initiative. And also, we can take advantage of the existing structure. As I mentioned, PAHO has a secretariat, has a regional validation committee. We have several technical advisory groups for HIV and syphilis that we can use, and the expertise and also the work of these people. And we have also several, even not PAHO only, but WHO has several of guidance documents, tools, progress reports, and methodologies and process that already exist for HIV and syphilis that could be adapted and updated to include hepatitis B. And we've also seen that the EMTCT is a topic that attracts attention from the highest level and political commitment at the highest level. So it was also a good experience to see, and we could also leverage on that. And the MTCT is strengthening the MCH the MCH programs and the MCH systems. And I think we reached a stage where the MTCT component is perceived as a quality marker of the whole MCH systems. So those are the opportunities that we can leverage on and to include other disease. And here the region started with hepatitis B and Chagas. And when it talk about hepatitis B, we are also building on the experiences of the strong immunization programs here in the region. Countries here have started vaccinating against hepatitis B during the 80s, and after decades of vaccination and scale up of the coverage of the vaccine, resulting here in a very low prevalence of hepatitis B in the region. We have all countries and territories have included the hepatitis B vaccine in the first year. And by 2020, at least 17 countries, according to some estimates, may have already achieved the elimination targets for hepatitis B among children. And we have very good, we have very high coverage of hepatitis B over the years. For the 3 doses, it reached 84% in 2019, the birth dose 73% as of regional. And we estimate that 90% of the birth cohort here in the Americas are in places where the birth dose is available. And as more children are born protected against hepatitis B, and new generations born in places where the vaccine is available, the birth dose is available, we still have to address some of the already existing cohorts of infected people that includes young women in reproductive age. And we estimate, some models estimate around 10,000 new chronic infections for hepatitis B in the Americas, and around 56% due to perinatal transmission. So to address this, I would say the last mile, we published the regional elimination framework of the quadruple elimination, as I mentioned. With targets for HIV and syphilis are the same as I did before, and we add the hepatitis B impact target of 0.1 prevalence among 5 years old, aligned with the global discussions as well, and the also target for Chagas. And on the programmatic area, we also defined some programmatic objectives regarding the coverage of interventions. And align with the HIV and syphilis, we add some, beyond the immunization, we add some targets on the coverage of HB and coverage of testing. And this was before the new recommendation on treatment for published by WHO. So this new intervention in this document, it was encouraged. We were encouraging countries to add the treatment and prophylaxis, but since it was not a recommendation by WHO, we could not include it as a target, but now it's going to be revised. And countries here, how countries are implementing, we know that all countries in the region, as I mentioned, have included the hepatitis B in the childhood in the first year. We have 31 countries and territories that have included the birth dose, universal birth dose. We have 22 countries that have already included the immunoglobulin to exposed infants, and 24 countries reported that they are screening pregnant women for hepatitis B, HBsAg. And we have 19 countries that have committed to the elimination of mother-to-child transmission of hepatitis B, as they are reporting that they have included these targets in their national health plans or national strategies. And that was, I think that's a great improvement from the baseline that we have from 2014, when we published the viral hepatitis regional plan of action, where 5 countries have reported committed to the elimination. That was improvement to 19 in 2019. And as countries are trying to implement, we have supported these activities and implementation in pilot countries, and also countries are increasing and scaling up their intervention, their response to the MTCT to integrate hepatitis and Chagas. We've had some good experiences of how countries are managing to introduce and to include this. But I think most countries and real good experiences to how to integrate and to do an integrated approach. Most countries are starting with a situation assessment where they review all the policies, services, interventions, even epidemiological information for the 4 diseases, for the 4 diseases included here in this framework. Most countries, several countries, they were already responding to these issues in individual efforts. So they needed to do an assessment, and this assessment, they would identify what is missing and there's some barriers and what they need to improve. And then based on this, they are designing some national strategies to address the 4 diseases as a group. And many countries, as I mentioned, they were already responding to these issues, but especially for hepatitis, the MTCT initiative is an opportunity for the initial response to viral hepatitis overall. So countries, they were not responding to hepatitis, but this was an opportunity then to start responding through the MTCT initiative. Many countries also, as I mentioned, it's a topic that attracts the attention of the highest level. So we've seen some good experience for the high level commitment, including a presidential decree that was, for example, the case of Uruguay, that's the new policy to start screening pregnant women for the 4 diseases came from the presidential level. So it was a very high level commitment, and also with ministerial technical notes defining the new criteria, the new procedures that the services need to follow. And many countries are doing this as a national effort, but we have some good experiences of subnational approaches as well, where provinces are in integration and discussions with the federal level, but they are doing some subnational approaches, like in Argentina and Mexico as well. They are promoting some subnational approaches in their provinces, in selected provinces. Regarding financing, several countries here in the region, they have universal public health systems, and they are going through the inclusion of these new interventions, especially screening for pregnant women, with in a way of incorporating new technology and new procedures in the public health system. With this inclusion, few countries, according to the internal regularizations, etc., they can secure the budget from the health system, and then can secure the budget for screening, for interventions based on this procedure and this instrument. Other countries where the private sector is strong and it's regulated, they can enforce or make new rules that national health insurers, private health insurers and health plans, they must cover for the hepatitis B screening or other interventions for pregnant women and for the children. And we even seen to avoid barriers and to facilitate the access to confirmation tests, we've seen the public sector securing the confirmatory screening. For example, here in Peru, we've seen a technical note that the private sector, they must provide the screening, the serological screening, but the viral load and the confirmatory tests are secured in public reference laboratories. So these would avoid barriers from the private sector as well, and would facilitate the monitoring of the pregnant women as well, since even the private sector are referred to the public laboratories. A good experience as well would be the centralized procurement of commodities. with tests or even drugs being procured at a central level, so they can have some power to discuss and to negotiate with the industry, and even make use of international procuring mechanisms, as example of the PAHO, a strategic fund that can support countries in accessing these drugs and these commodities at a lower price, and they can consolidate the demand from several countries, and they can get even more negotiation power. And after planning and after securing financing, countries have started the implementation with some capacity building. We've seen that dissemination of this new framework, this new strategy, followed by training of healthcare workers, is a good way to start. And we have even some experiences from Brazil, for example, where they develop and publish protocols for the investigation of infected newborns. So every case of confirmed infected HIV, syphilis, or hepatitis, that will trigger a thorough investigation so they can identify barriers and gaps and later on adapt and update the system. So every city, every major city with higher, big cities in Brazil, medium cities, they have their own committee to investigate these cases and then to proper changes in the flow so they can prevent this from happening. And we don't know, we know that countries are implementing, so we have countries that are implementing these, updating their policies, publishing national strategies, or even including new technologies. But the problem now, we have a gap on the information on the coverage of these interventions, because we don't know exactly how many women are being tested. We know that we know exactly how many are being tested for HIV and syphilis, but we don't know for hepatitis B. And what we are promoting now and countries are doing is to revise and update their information systems, so we are able also to collect information on hepatitis B, interventions of hepatitis B as well. Uruguay is a country that is updating their perinatology information systems with some indicators for hepatitis B and Chagas as well. So we hope to have more information on in the future, and as we promote countries, as encourage countries to update their information systems as well. And regarding the next steps here in the region, we are continuing to promote the interprogrammatic work, as I mentioned, that I think is the main lesson. But with we also focus on the strengthening of the maternal and child health. We do believe that the countries which had the most successful experience in implementing the process was led by the maternal and child health management instead of hepatitis or HIV programs. So it was on a higher level within the organigram of the Minister of Health. We are encouraging promoting countries to expansion their HBV interventions, both a screening, vaccine, and also the birth dose implementation, as we still have several countries to implement universal birth dose. We need to address the data gap, as I mentioned, to advocate for the inclusion of indicators of hepatitis B, as we still don't know exactly what's going on the coverage of these interventions. We are discussing also with Geneva, WHO at the global level to identify and to agree on methodologies and process for the validation of the elimination. We are continue to support countries in the access and reducing the cost of key commodities, including diagnostics and medicines. And we have an instrument here in the region, that's the strategic fund, the PAHO strategic fund, that has a really important role in facilitating the access to several countries. And we are continuing to promote this idea that the MTCT as a milestone for the elimination of hepatitis B as a public health problem by 2030. And yes, thank you.
Thank you so much. It's a great overview. You really touched on a number of important points. Look forward to exploring in more detail. But let's move on to get some thoughts from the African region. We have with us Dr. Casimir Mniznego, who's a medical advisor in the WHO Africa Regional Office. is now the acting focal point for viral hepatitis prevention in the region and has been a longtime advocate of prevention of mother-to-child transmission of HIV, syphilis, and now hepatitis B. Dr. Casimir?
Hi, John. Hello, good morning, good afternoon, good evening. It's a pleasure for me to present the triple elimination pathway in Africa. And I'm so pleased to be with the main advisor of the first lady here in Chad. I'm in Chad now. She's greeting you. Salut.
Bonjour.
Okay, thank you. Okay, this is my presentation. We can go. Slide, please. Okay, that is some record about triple elimination. It targets HIV, syphilis, and viral hepatitis B. And what we are doing to the mother during the antenatal care service package, and for the treatment, what we are doing if mother is tested positive, and also what we are doing to the newborn. And globally for hepatitis B, we have a rapid test for mother, and if the mother is positive, we recommend to give tenofovir, and at the delivery, we give the birth dose hepatitis B vaccine within the 72 hours. Slide, please. It is just to recall what was the impact of the introduction of viral hepatitis B in the routine vaccination. We know that before vaccination in Africa, in the world, we had 4.7% of prevalence for under 5. But after the routine vaccination, we can decrease this prevalence to 1.3% in 2015. But it remains something to do. And we know that to continue to reduce this prevalence, we must introduce the hep birth dose in order to continue to reduce the hepatitis prevalence in our countries. Slide, please. It is a situation of prevalence, hepatitis prevalence in Africa countries. As you can see, Chad is the most prevalent, with one out of 4 people are chronically infected by hepatitis B. And here we can see the situation of all of the countries having the prevalence more than 8%. It's a very big issue for Africa to consider that the level of HIV hep B prevalence. Slide, please. And here we have the situation of countries who now currently implementing the hepatitis B dose. We have until now just 12 countries in Africa. It is a very big problem. As you can see, Chad, who is the first one, is not implementing the triple elimination. It is why now I am in Chad and discussing with the First Lady main advisor to see how we can advocate enough to introduce the triple elimination in Chad. Slide, please. And here, for us, the engagement of the First Lady in OAFLAD. OAFLAD is an organization of African First Ladies for Development. It is a very big opportunity for us because they are already engaged on PMTCT in different countries. We have about 28 First Ladies already engaged on OAFLAD. And from them, we have 17 First Ladies who are strongly engaged on PMTCT. Here it is the discussion I had with the main advisor of the First Lady, with whom I am now. And here you can see the First Lady launching the agenda action plan for 2019 to 2012 in order to launch the agenda for PMTCT. And it is the first point in her agenda. So we are just taking this advantage to involve our hepatitis program in her agenda. Slide, please. Okay, the key point we can, the take-home message is that we have 33 of 47 countries have prevalence more than 5% in general population, and only 12 countries are implementing the universal birth dose. The OAFLAD, which is the organization of African First Lady, is an opportunity for us to strengthen advocacy in the Africa countries. We have 28 countries with First Lady very strongly engaged in OAFLAD, and 17 from them are ready to work with us in order to go ahead with this program, the triple elimination in their country. It is now a necessity to extend the birth dose in the country, in African countries, and also to strengthen the hepatitis screening for pregnant women in an antenatal package in Africa. Those are the key message we have, and it is for me my commitment to work on this in order to do something for Africa countries. Thank you very much for your attention.
Thank you for that overview, Casimir. That was great. It really shows the immense need for improved prevention of mother-to-child transmission of HPV in Africa. And glad you're working on that. So we can seize the moment here. Let's move on quickly to get some global comments from Dr. Morkor Newman Owiredu, who is the lead for prevention of mother-to-child transmission at WHO headquarters in Geneva for HIV, hepatitis, and STIs. Really fortunate to have her here, and look forward to your thoughts about what's been presented, as well as some other activities that are going on globally you would like to bring to our attention. Thank you. Dr. Morkor.
Thank you so much, John, and good morning, good afternoon, good evening, everyone. I don't have a presentation, but just some thoughts off the top of my head, and just to thank the presenters because they have been very informative and I'm sure extremely useful for all those who have participated in this webinar. First of all, just to say that triple elimination as an initiative is really important for us because it improves reproductive health in general. And we look not just as reproductive health, as reproductive maternal, child health, adolescent health, all get well addressed because they need to be strengthened if we really want to respond better and get all our programs in place to eliminate mother-to-child transmission of the 3 conditions. I think we also, it did come up quite clearly in the PAHO presentation, but also there's this issue about us involving our clients, that is the women, the pregnant and breastfeeding women who are in the health system, because it's able to get them to help us to remove the barriers which have been preventing them in general from accessing such interventions. So you find that we are better looking at and addressing stigma and ensuring there's better uptake of these interventions. I thought it was really interesting that, for instance, in the presentation from Thailand, they actually acknowledged that they recognize marginalized populations and the need to emphasize investing more and getting the interventions to them if we really want to eliminate mother-to-child transmission. They're looking at not just the mother, but also the father and the rest of the family. So that all brings up those really good issues which we have to address. Then also we have the fact that this is all dependent on a strong health information system. The countries, as you can see, some have actually been able to show us that their health systems are so reliable that they're able to tell us the actual uptake because they miss very few clients. And this, for instance, the 95% coverage that we see, this also helps us to ensure that we are actually getting to all the women who need the services that we talk about. There's also the advantage of the decentralized approaches which we have seen, which enables the healthcare workers to increase access to testing and treatment. It's not all the way there, because we acknowledge that in, I think, was it in Cambodia or Thailand, they haven't gotten to all the districts. So yes, there's still quite a bit of work to be done, but importantly, it has started and it will get further. And I'm sure that it will soon reach that. We also looked at the fact that there must be investment in the platform for integration. That's the reproductive and maternal and child health platforms. Because if we don't integrate these services, it's not likely that we will get to eliminate mother-to-child transmission by 2030, as Thailand has proposed. It mentioned that, and it's looking at all the domains. It's not just the programs, but the data. It's also looking at the laboratory services, because we have to ensure that we're actually getting all the infections, identifying them and being able to treat them. I think lastly, triple elimination is not as simple as it looks. There are complexities which have to be addressed, but the emphasis, like I said, is in the need to integrate and to use the existing platforms that we have and make sure that they are invested in, because if we don't invest in the existing platform, be it the health management information or the reproductive health platform or the child health platform, to be able to get the immunizations, for instance, the birth dose, to get them to be timely. If we don't invest in these, it's not likely that we will be able to reach the elimination targets like we plan. And then last but not least, probably should have come first, is the really impressive political commitment, which must be there if we really want to move. So just to say congratulations to the presenters and to the regions who are involved for their progress. We're not there, but we are definitely moving in the right direction. And we hope that soon we'll be able to say that triple elimination is not just something we talk about, but a reality. Thank you.
Thank you so much. Those were great overarching comments. I wanted to see if any of our presenters or other discussants had any comments in response to Dr. Morcor's overview. I think what we're recognizing is that hepatitis B testing is an underutilized intervention in the prevention of mother-to-child transmission. We have an excellent example of how it can be fully applied in the case of Thailand, how a country has really seized upon this as an initiative in the case of Cambodia. And then there are other countries that are in various stages of implementation. And that it's really, as Dr. Morforo was mentioning, it's really striving to bring together a comprehensive set of interventions to really maximize protection of the infant and also seek to improve the health of the HPV infected mother moving forward. And that's really what we have in front of us to improve upon. We are making progress. I do take heart in the fact that the world has achieved the 2020 goal of reducing HB surface antigen positivity prevalence to less than 1% among children less than 5, which is an incredible achievement, and actually it meets the Sustainable Development Goal of that level, as well as the WHO interim target for 2020 for hepatitis B elimination. And indeed, that was the only SDG goal achieved in 2020 was that reduction in HBV prevalence among young children. And I do think that really is indeed a very big positive step in the right direction. And so we are really marshaling the resources to make the final goal of reducing prevalence to less than 0.1% possible by 2030, as Thailand has already achieved and demonstrated. I see if there's any other comments. If not, I want to thank everyone for your time. All of the presentations, the full slide sets are up on our website at globalhealth.org. I want to again thank everyone. I look forward to working with all of you in the future to improve the prevention of mother-child transmission of hepatitis B around the world. Thank you. Have a good day. Thank you so much.